So we're in a really exciting time right now for behavioral science, where we're starting to see a lot of the principles and ideas that are really well grounded in science that we've spent decades studying, finally starting to be brought to scale. And you may be familiar with some things from behavioral science and not even know it. These are some popular books that you may have read or at least heard about. If you're a podcast junkie like I am, you may also be hearing about these things in these spaces. And then there are these other small happenings. This is Danny Kahneman winning the Nobel Prize in Economics in 2002. And just last year in 2017, Richard Thaler also receiving the Nobel Prize in Economics. And I think it's worth noting that while both of these individuals received a prize in economics, their research is well grounded in behavioral science. And in fact, Danny Kahneman is a psychologist. There are also some real-world examples of the popularization of behavioral science that you might also be familiar with. So you may have heard of the concept of life hacking, this idea that there are small ways that you can integrate these principles of behavioral science to revolutionize your life and make everything better. Or the concept of tiny habits, this idea that by taking these incremental steps, you can start to make major changes in your life. Now, there are pros and cons to this popularization of behavioral science. As a behavioral scientist myself, I am thrilled that this is now becoming part of the mainstream dialogue, and people no longer look at me like I have three heads when I talk about some of these principles. That's a real win. Another thing that I think has been a real benefit of these types of publications and podcasts and Nobel Prizes is that it has brought into common dialogue these things that have otherwise existed in journals that like 5 people read and that otherwise collect dust on shelves. And so those are all things that I think are really great about this, because it gives us an opportunity to bring into the field of digital health these principles. And because they have been so nicely distilled, you're no longer having to deal with a lot of difficult jargon. You're able to think in terms of these really practical things that you can apply, whether that is in an app, whether it's in a solution that you're integrating within care delivery that helps physicians and other care providers to deliver care, et cetera. Those are all wonderful things about this popularization of behavioral science. But there have also been some potential downsides, and that is by simplifying a lot of these techniques, what we've created is a whole bunch of people who feel like they are experts because they've listened to a podcast or read a book. And nobody, as somebody who's been working in digital health for, 10 plus years, nobody would ever expect that if I read a book about coding, that I am now an engineer. And yet somehow there's this idea that I behave and therefore I'm a behavioral scientist. So I think there is an opportunity here not only to take these principles, but also start to think about, do we have the right experts in the room and on our teams to really make sure that we have an evidence-based approach to the way that we are addressing health and health behavior, and that we're thinking not only about some of those short-term changes where they are appropriate, but that we're also thinking about more long-term and sustained change. And so here I'd like to suggest that we need to change our approach a little bit. So we've all heard the concept of nudge. We hear a lot about this idea of architecting our environments, and there's a lot of benefit to that. And those approaches, whether they be nudge or changing habits or making habits, sometimes does the trick. It works really great for behaviors like vaccines. You don't need to do a vaccine every day. You do vaccines like once a year, sometimes like twice in a lifetime. Health screenings, again, these are things that you do once a year or once every 5 years. These aren't things you're doing all the time. Seatbelts, that's kind of an easy habit. When I was in the taxi on the way from the airport yesterday, the cab driver commented, "You put your seatbelt on." I usually have to ask someone to do that. And I couldn't remember the last time I sat in a car and didn't sit down and the seatbelt magically ended up on without any thought. But for most of what we're trying to change, when we're talking about addressing the major contributors to health and healthcare costs today, things like nutrition and dietary behaviors, physical activity, sleep, stress management, preventing or managing chronic conditions where we're asking people to engage in continuous self-monitoring of their own behavior or of some physiological indicator, or we're asking them to take medications. Those are things that people have to do at least daily. And nudge is often not enough to get people to engage in those behaviors long term. So how do we start moving from this idea of nudge, which might be a great way to get people started, to thinking more about these sustained forms of motivation that are likely to keep people going, even when it's difficult, when it's no longer novel, and when it's something that they're being asked to do repeatedly on a daily basis. So I'm going to talk a little bit now about a different approach to human motivation that you may not have heard of. This is based in the work of self-determination theory, and I'm going to try to spare you a bunch of jargon in this and talk with you about this because I think this is a highly practical approach to human behavior that has gotten not quite enough attention yet in the mainstream. So a lot of times when we talk about motivation, we're really talking about, is somebody motivated, yes or no? Or how much motivation does a person have? But I'd like to challenge us today to really start thinking not just about the amount of motivation that a person has, but really what is the quality of that motivation? Because the quality of the motivation matters. So if we were to think about motivation existing on a continuum, we can think about a motivation. This is something you're familiar with. This is when somebody doesn't do what they're supposed to do. We can also think about extrinsic motivation, which I'll get to in a minute. Intrinsic motivation is an easy one, right? It's like somebody likes to do the thing, they're doing the thing, we don't really have to mess with that. Extrinsic motivation is a place where we have a little bit more nuance and an opportunity to think in a slightly more sophisticated way than we often do when we're thinking in terms of motivation as being just high or low. So amotivation, when somebody isn't motivated. Our typical approach is when somebody isn't motivated is to educate them. Maybe it's that they don't know. And there may very well be instances where that is the case. I will say, having worked in health behavior for about 15 years, we are currently at a place in public health and in population health where education is often not the issue. I'm not going to walk into the McDonald's down the street and surprise anybody with the news that they may be not making the most healthy choice. That's not news. They know that, and yet they're there. They're not making a healthy choice. So education may or may not do the trick, or it may or may not be relevant in a particular context. Another thing that we often do with amotivation is we try to prod people, right? Like carrot and stick them all the way till they do what we think they need to be doing. And what I'd like to offer here is I think we have a real opportunity when people are not doing what we think they should be doing to understand why. I do a lot of work in smoking cessation, which I'll talk about in a little bit. Most people who smoke know that smoking is bad for them. Again, not news. And most people who smoke have tried to quit and failed, sometimes dozens of times before they come to a program that we're offering. And so it's not that they don't know that they should quit. In fact, they do. It's often that they don't feel that they can because they've got lots of data to suggest that, in fact, they cannot. So part of amotivation may be a lack of perceived competence. It may also be a lack of value. So we talked a lot about this throughout the day today, where we're talking about populations who have incredibly complicated lives. They've got lots of stuff going on. Maybe they live in a neighborhood that's not especially safe. Maybe they're concerned about being able to pay the bills so that their electricity stays on. Maybe they're not sure if they're going to be able to feed their family through the end of this paycheck cycle. They don't have bandwidth to monitor and change a complicated behavior like changing their diet or quitting smoking or managing their diabetes. And it's not that they don't want to, it's not that they don't know that they should, it's that there are other pressing things in their lives that are taking precedence. And when we think about amotivation in those ways, the solutions we come up with are going to be very different. I'm going to move to the other side of this continuum, intrinsic motivation. This is the happy place. This is when somebody wants to do the thing, they're excited about doing the thing, you don't have to convince them to do the thing. Most stuff in health does not fall into this camp. Doing finger sticks, not intrinsically enjoyable. Quitting smoking, not fun. So most of what we're talking about when we talk about health, when we talk about healthcare utilization, when we talk about health behavior change, is really going to fit in this extrinsic motivation space. Now, extrinsic motivation, if we start really high level, is really about engaging in a behavior or doing a thing to get some outcome. Now, that outcome that you're striving for may vary in terms of exactly how far external it is. So on the extreme left side of the screen is external regulation. This is what we get when people are punished by rewards. And why does that matter? Well, those are only going to last so long. They're not going to do the trick long term. It may be what gets people in the door, but it is not going to be what keeps people going. Moving a little bit more inside, people can also inflict punishments and rewards on themselves. How many of you have had the experience of going on vacation, going out to dinner, and overdoing it a bit? And how did you feel afterwards besides hungover? You felt bad about yourself. You felt guilty. And this is a way in which we inflict those punishments and rewards on ourselves. Again, it might make for some short-term change, but isn't going to be the thing that keeps you going. Next up is identification. This is the point at which somebody is starting to take on the behavior as something that is in some way personally meaningful. And this is a really important and valuable lever for us to potentially tap into when we're working with people. Remember, I was talking about amotivation, how sometimes what is keeping somebody from engaging in a behavior that we think they should be doing is that they've got other stuff in their lives that's more important, that's louder. Those are energy sources that we are missing out on tapping into. If you are worried about your family, that says to me that you value your family. So let's tie that desired access to care, that desired health behavior change. Let's turn the lights on for you so you can see how your accessing care actually makes you a better caregiver. It actually makes you more available to your family. Let's create some identification. Integration is where we've got some congruence going on here. So, for example, somebody might think of themselves as a person who is a good person, who takes care of others, who takes care of themselves. And part of kind of building this momentum for them is really about helping them to connect those dots between those other areas of their lives and how that matches up with those broader goals and values that they might have. So most of the space we're going to be working in health, in healthcare access, in healthcare delivery, in health behavior change, is really right here. Because as I said earlier, most of this stuff isn't going to be fun in its own right. It's really going to be about how do we help the person to see the personal value in it, and then how do we help them connect the dots between the desired behavior and what's most important to them so that those things become aligned. So how do we help people move through this continuum? How do we get somebody who might be amotivated or who might be only doing this to avoid a penalty or surcharge with their insurance? How do we get them to move along that continuum toward those more internal forms of motivation? It's by supporting basic psychological needs. That is a terrible translation between technologies. Good thing I know these things. So autonomy is not about independence. It's really about the fact that people want to be involved in calling the shots in their own care. They want to feel like they are, in some ways, their own change agents. Now, this doesn't mean that you're wheeling somebody in for surgery and say, hey, what scalpel do you think I should use today? That is not the way to support someone's autonomy. That's a good way to freak them out right before surgery. Rather, supporting someone's autonomy is about providing them with meaningful choice. There are lots of ways for people to get from point A to point B, whether we're talking about going for a follow-up appointment, or we're talking about somebody who is trying to be more physically active, or we're talking about somebody monitoring their glucose. Give them choices about how to do that. I've found in practice that providing people with about 2 to 3 options is about as much as the brain can handle before it feels like choice overload. But allowing people an opportunity to make a choice is a good way to support their autonomy. The second psychological need is relatedness, and this is one that, again, I've heard whispers of throughout our conversations today. People want to feel connected to other people, they want to feel understood, and they want to feel valued. And if the way that we're approaching health behavior and health behavior change doesn't address this, doesn't express compassion for the other things that are going on in their lives because they're struggling, doesn't acknowledge that they may be feeling stigmatized because they're dealing with a mental health condition, and we still stigmatize that and don't provide good care for that in our culture, that's an opportunity for us, through our technologies, through the ways that we support care delivery, to promote change. Finally, competence. This is a no-brainer. This is one we're all really familiar with. People want to feel capable of being able to execute on the thing that we're asking them to execute on. And so sometimes, and this is where a lot of behavioral science stops, is really around competence. So the idea of tiny habits is really nicely well-grounded in this idea of competence. That by building on things a little bit at a time, it becomes a digestible thing for them to tackle, rather than it being like the whole elephant all at once. So I've said a lot of words, and you may be thinking, but how do I do this? How do I make this practical? So at Carrot and our product Pivot, we are trying to do a lot around promoting sustainable forms of motivation. And what we've done with this product is we have a 3-pronged integrated technology that incorporates an FDA-cleared carbon monoxide breath sensor, a year-long app program that integrates the latest in behavioral science and in evidence-based treatment for working with people who smoke, both those who want to quit and those who are not ready to quit. And third, we provide dedicated human coaches who interact with our participants through in-app chat. It's asynchronous, so nobody has to set up an appointment. You're always interacting with the same coach, so you're able to build a relationship with that person. And so I want to talk with you a little bit about how we're using these principles from self-determination theory and integrating them into our product, Pivot. So here's how we're supporting autonomy. So as I mentioned earlier, we have an FDA-cleared carbon monoxide breath sensor. This provides people with information about their exhaled carbon monoxide. For those of you who don't know, carbon monoxide is one of the metabolites of smoking, combustible cigarettes. And so how much you exhale into this sensor is an indication of how much exposure you've had, not only to carbon monoxide, but also to other toxicants within cigarette smoke. So how does this support autonomy? This provides a really fantastic opportunity for people to self-reflect. For decades, our story with smoking cessation has been, stop smoking, because someday you might get lung cancer. Nobody cares. If I don't have lung cancer today, my capacity to maybe get lung cancer in 40 years doesn't really matter. But this brings it in the here and now. And we present the data to people in a way that they can digest it, that they can process it, and that they can see what it means for themselves. So this is a way that they're able to create their own reasons and for them to have some buy-in to what's happening in their body and for them to make decisions about what they want to do with that information. Through our coaching program, we also help people to connect the dots. So this is a sample coaching interaction. This is a real interaction between one of our coaches and one of our participants. And the coach asks, how does smoking make you feel during your me time? During a previous conversation, the person had said, like, this is my downtime. Like, this is when I get to, like, unwind. This is the purpose that smoking serves for me. And what happens for this participant is she says, I feel shameless, powerless, unclean. I'm willing to accept the thought of illness and disease. I'm embarrassed. That's a really powerful moment because here we have a person who is acknowledging feeling really bad about doing this behavior that she also values because it provides something for her. It provides an escape. It provides a way for her to unwind. And what her coach does here is acknowledges that she's shared something really profound with her. And rather than going down the rabbit hole, says, well, what makes you feel strong and powerful? What makes you feel in control? And she says, I feel strong when I'm not basing my to-do list on time to go buy a pack of cigarettes and when I decide not to light up. And here's a way that it really changes the conversation for this person, because she has identified what purpose quitting would serve for her. It becomes a way for her to feel powerful and in control. And these are some of the things that some of our participants have told us that indicate to us that they're feeling that their need for autonomy has been supported. So I'm not going to read them all to you. I'm just going to read a couple of them. Pivot speaks to your logical and human side. You're looking at yourself. I learned that quitting is something I want to do. And want is a really important word there. It's not something that I should do. It's something that I'm choosing to do that's important. I think the biggest thing was really the awareness and putting it at front of mind. Again, this is speaking to the importance of creating an opportunity for people to reflect a bit. Supporting competence. Again, we want to support people in tackling what is a really complicated behavior in really digestible ways. So we present people with opportunities to do a daily challenge. And through that, they're able to tackle one piece, just one piece of quitting smoking. Not the whole thing, not quitting all of your cigarettes, but just one piece. And we also want to encourage people to celebrate small successes. Too often, smoking cessation is a dichotomous, did you quit, yes or no? And we want to provide people with an opportunity to celebrate the wins that they have along the way, because that's another way to facilitate their feelings of competence. And again, I won't read all of these, but these are some quotes from our participants. The coach was a big thing because she saw in me what I wasn't seeing. It's really nice to get a pat on the back from somebody. And finally, supporting relatedness. One of the things that's really important to supporting relatedness is creating a circumstance or an environment where people feel accepted. When we're talking about people managing chronic conditions, managing a behavioral health condition, trying to quit smoking, managing their weight, there's a lot of stigma around all of those things. And people feel that stigma. And so when your program or when the way that you support care delivery helps people to feel accepted, that's incredibly powerful. So here are just a couple of snippets from 2 different coaching interactions. These are initial coaching interactions, and one of the things our coaches lead with is tell me something about yourself. Tell me something you want me to know about you and how smoking fits into your life, or tell me something that you feel that other people don't get about you and smoking. Another piece of relatedness that is really important is this idea of quieting the guilt, quieting the self-flogging that people engage with. And so part of that is about kind of creating relatedness with oneself. And here, one of the things that we do is we try to normalize the idea of slips and relapses. This is not a completely linear process. You're going to stumble. That's okay. So, how do you use this for competitive advantage? Behavioral science can be used in a lot of really powerful ways. Importantly, by using principles from behavioral science, you can move from engagement to retention, especially when we're talking about these more sustainable forms of motivation. And you also have an opportunity, particularly when you're working with a savvy behavioral scientist, to identify, define, and measure what is meaningful engagement, whether that is engagement with a health system broadly, engagement within one's own care, or engagement with a digital solution. I think one of the things we've gotten really hung up with on digital health is this idea of having lifetime membership. And I have to tell you, I don't think that's what our goal should be. If somebody is using the Pivot program and they stop using that program because they have quit smoking and they are doing well, that is a win, even if they stop using the program before the year is up. Why is it a win? Because it served its purpose. Fitbit's gotten a lot of criticism, like people stop wearing Fitbits after 6 months. Does that mean that people stop walking after 6 months? I don't know. Nobody's ever asked that question, but I think it's an important one, and I think that's something that we need to keep in mind when we're thinking about what does engagement mean and what is quality engagement. A savvy behavioral scientist can also help you to identify metrics. Now, we all think about some of the obvious outcomes, things like percentage of weight loss. Did you quit smoking, yes or no? What's your hemoglobin A1C look like? And those are, of course, important metrics for us to consider, but there are others to keep in mind that are indicative of you being in the pathway to those obvious outcomes. Things like progress. Did somebody lose some weight? Have their A1C levels come down? Some. Indicators in the pathways to change. Behavioral scientists love talking with you about what they will call mediators and moderators that involve a whole lot of complicated statistics, but basically what that means is, are you changing something that we know is part of the process of getting someone to that ultimate outcome? And they can help you to know what those things are. They can also help you to know, is this working the same across populations, or is this working especially well or especially poorly in some populations? And I think return rates are something that's really important. Again, whether we're talking about access to healthcare, we're talking about using a digital solution, if somebody stops using your thing, your app, your system, but they later come back, that's an indicator of success. Why? Because that means that you have created an environment that they feel safe coming back to. And when we're talking about health and healthcare and health behavior and these things that people feel tremendous amounts of guilt and shame about, if you can alleviate that a little bit, you've done well. Now here's the catch. You cannot build a system in your healthcare, you cannot build care delivery systems, you cannot build apps, and then sprinkle some behavioral science on it like fairy dust. That's not gonna work. You really do need to integrate this from the ground up, and that's why it's so important to make sure that you have the expertise at the table to have these conversations. We've done a really good job of leveraging some of these principles for behavioral science in marketing efforts, and we should continue to do so, but we also need to integrate them into our solutions. And with that, I'm done, and I'm happy to take any questions.
Does anyone have questions?